Welcome to No Filter Doctor, where we cut through the health hype and dig into what's real, what works, and what's backed by evidence. I'm Dr. AK. Let's get into it. Hey everyone, thanks for joining me today. Before we get into this week's episode, just wanted to give you the heads up that I was finally able to secure a guest. I'm pretty excited. It's Dr. Kim Einhorn. She is a menopause expert, and she and I got into a lot of the different things about women's research and atypical signs and symptoms of menopause. But I wanted to let you know that this is my first video recording, so I did use some new software. We'll see how it all turns out. And if you listen in the car or in your headphones or earbuds, it's a moot point. It's not going to make a difference for you. But if you're one of the people who follows along YouTube, now there's going to be videos of the podcast. I'm going to try and do this a little bit more moving forward. So without further ado, I am going to give you my episode with Kim. Take care, everyone. Hey, everyone. Welcome back. This is what I look like. So as you can see, I have my first guest speaker. I'm so excited. Last week, we talked about how I'm a nobody in the podcasting world, and now I am still a nobody, but I found an expert who's willing to come on and talk to us about part 2 of the menopause care that we started last week, the perimenopause menopause care. And so I'm super excited. I have Dr. Kim Einhorn here today, and she is a board certified OB GYN, certified through the Menopause Society, and started her practice called the MP Collective on the main line. She is absolutely wonderful, and I'm so excited that she's here to talk to us a little bit more about menopause. Kim, hop on in and say hi and introduce yourself.
Well, thank you for the introduction. Yes, like what you heard is true. My name is Kim Einhorn. I've been an OB/GYN practicing for the last 23 plus years out here on the main line. I did my residency through Jefferson and basically practiced full scope OB/GYN for my entire career. But as you know, in the last few years at my former practice, found that, as I got older, all of my patients aged with me. And so I was primarily doing menopause and perimenopause for years. And in that old system, wasn't really being given the time to be able to actually, give perimenopause the time and attention it needs. So just this year, I decided to go off on my own and open my own practice that specializes just in menopause and perimenopause and midlife women's healthcare. It is called the MP Collective, and I'm right here in Bryn Mawr, and I'm getting to do exactly what I love every day, all day long.
That's awesome. I mean, you guys can see for those of you who are watching the video, you can see the Eagles, the Philadelphia Eagles in the background there.
This is my artwork.
So pretty convenient. You are on one end of kind of that main line, and I am on the other in Ambler, and our paths have crossed when it comes to hormone care, because this is your bread and butter, and it is very much a part of my practice with health optimization. So I'm just really excited to have you here. And so last week, what we talked about was just this full circle of hormone replacement therapy. We went into the Women's Health Initiative and how, a lot of the women that were in that study weren't even in the age demographic of the people that we typically start on hormones. And some of the data analysis, if you go back and you look at it again, it really wasn't statistically significant, but they had a press conference to talk about the evils of estrogen therapy and hormones. And I kind of mentioned to everyone that the hormones aren't even the same beast. So a lot of the care that we provide today, it's so different than whatever it was that was around during that Women's Health Initiative. And so we're getting better. We're getting better with women's health and research in women's health, but we're still not quite there yet. And one of the areas where there is still a big gap are a lot of these signs and symptoms that are associated with perimenopause and menopause. One of the things that I was really excited to talk to you about today is the fact that there is a lot out there with hot flashes, palpitations, issues of sleeping, right? We hear about that stuff all the time, but there is a whole world of other symptoms that women are experiencing, and it never gets attributed to menopause, perimenopause. And these women go, they speak with their physicians, and their physicians run a thing of labs, and they're like, it's not your hormones. Everything's great. Eat more fiber, exercise more, and you'll be better. So I would love to hear kind of your perspective on this topic, because the research, it's not quite there yet. Like we're getting more and more data. Like we know about the musculoskeletal syndrome, which kind of links into the body aches. But I imagine in your practice, you are seeing a full gamut of different signs and symptoms that are not really addressed by research. So what has your experience kind of taught you about all of this that we can share with everyone?
Well, what you say is definitely true. Since starting my practice, I've been surprised at how young my patients are coming in to seek help. Like, I have patients that are 35 years old. So, we know from SWAN data, that's the study of women's health across the nation, where they started enrolling women as young as 42 who were reporting their symptoms started between 6 and 8 years prior to that. So, we do know that symptoms can start in, even as young as your mid 30s. And I do think that one of the things that patients and physicians battle with is not recognizing that it could be hormonal or perimenopause unless it has the hot flashes and night sweats associated with it. And that can be a big problem for patients. And I do think that one of the things that I see on a daily basis are women coming in that don't have the hot flashes and night sweats. They don't have the vasomotor symptoms, but they have one of the first signs, which I think is the mood symptoms. And this is anything from just worsening PMS to drastic to going up that chain, more drastic anxiety, new onset panic attacks, new onset depression, to the drastic polar end of the spectrum, which is scary, which can be even newly recognized bipolar or even psychosis and suicidal thoughts. I did have a patient that came to me that had started hearing voices telling her to kill herself, and it was the first time it ever happened was in her mid 40s when her period started to change. So I don't know how to explain that. I do think that there can be underlying risk factors for people. And of course, not everyone experiencing mood disturbance in perimenopause is going to have that drastic situation. But, there is a huge hormonal link to cognition, emotion, and hormones. So I think that women, I think that I'm glad that the word is getting out there now that there's a panacea of other symptoms that you can experience through perimenopause, which without having the typical ones you'd identify, which are the vasomotor symptoms.
Yeah, I think for me, it was anxiety. And I know this now in hindsight. It was probably when I was about 38. I'm going to be 48 pretty soon. So about 10 years ago, I just started getting anxiety. And I've always been this nervous Nelly to begin with. And I would joke around with people and say, it's because I work in the emergency department. I
Mhm.
see the things all the time that you hear about on the news every once in a while. And
Right.
because of that, it, makes me really anxious. But then I was doing the things. I was doing the exercise, right? Because everyone's like, go exercise, that'll help. Change the way you eat. Well, I already eat pretty darn healthy to begin with. And then, don't drink. And I'm like, okay, I'm not going to drink. I'll cut back on the alcohol. And it was getting worse. And then a year ago, is when, I blew up my professional life. I went from being vice chair of education of a major academic emergency department to like starting my own practice. And so I thought because of that, that's why the anxiety was so out of control. And it was amazing and I too was reluctant to go on the hormones because of all of the dogma that was spread, especially in medical school, right? I mean, in medical school, I literally had a professor tell me, don't start people on hormones. Don't mess with that stuff. Like you're gonna kill people. And I'm just like, oh my
Mhm.
God. So you don't bother to listen. And then all of that dogma gets spread and you think, well, I'm not gonna go on them. And I went on them and I felt like a human again. Just like the anxiety was just gone. Here's the thing though, if you look at the ACOG guidelines with starting some of this hormone therapy, they don't mention a lot of these other symptoms. A lot of it is driven by those vasomotor symptoms. So when you have these patients come in, how do you recognize, oh, I think this might be hormonal, and how do you then reconcile that with the fact that there is this major professional society who I respect, I'm not knocking them, but, their guidelines say one thing, and then there's some of us who are like, "Well, the research kinda suggests the newer research suggests other things." How do you kinda go through that?
I mean, the research is really just lagging, which is why ACOG guidelines haven't been able to change yet. We don't have randomized controlled trials on whether estrogen cures joint pains and muscle aches. We do have research that does show when you treat the anxiety, the mood symptoms with hormone therapy, that they do have the same magnitude of impact as an SSRI in perimenopause. So guidelines always lag behind, and that's okay. It's not just OBGYN, it's literally every specialty,
Oh,
because
yeah.
the mountain of evidence that you need to gather to change a treatment guideline is huge. It is a Mount Everest. And so that's what practitioners like us are doing out there. We're helping people within the bounds of safety and seeing what works. And when I see a patient, how I differentiate between is this hormonal and perimenopause. Now, the definition of perimenopause, if you want to stick to hardcore definitions, the early stage of perimenopause, is the average age of 45, and that's when your periods are gonna start spacing out or coming closer together. The interval between day 1 to day 1 changes by 7 or more days. That's the definition when you fall into perimenopause. And then the late stage of perimenopause, which the average age is 47, is when you skip 60 or more days at a time. That's when you're starting to skip your periods. If people fit that criteria, obviously I know they're in perimenopause, and if they happen to have symptoms that coincide during that time period, that they've never had before, the answer is kind of obvious. You try hormones, see if they work. And we know hormones are safe for women to take. So there's no drawback, and they have potential long term health benefits. But I do have a fair number of women that haven't fit exactly into that criteria yet, meaning their periods haven't gone from 28 to 21 days yet, but their periods have started to change. The most common thing I see is their periods will become really, really heavy for those first 1 or 2 days and then abruptly stop and trail off to be spotting for the next 5 days. And that's a change. It's not like your ovaries all of a sudden one day just stop putting out estrogen, or there's a huge phase like on Monday, I'm premenopausal, and on Tuesday, I'm now perimenopausal amount of estrogen I'm spitting out. And then on Wednesday, I'm menopausal and not making any estrogen. It's a continuum that happens very gradually. So basically, it starts with just smaller menstrual changes and that lead to the bigger changes, that lead to the bigger changes. Then finally you stop, getting your period. So I rarely ever see anyone that's having just mood symptoms alone without some difference that they notice in their menstrual cycle. And the exaggerated PMS is usually where I see it starting. My patients will absolutely say that they become very short tempered right before their period. They have their irritability, they lose patience, they are taking it out on their children, they're taking it out on their husband. And then when they get their period, it just goes away. And they may never have had that before. Even those symptoms, without any vasomotor symptoms, actually respond very well to hormone therapy, be that in the form of a birth control pill or the more traditional menopause hormone therapy that we use.
Yeah, and just for everyone who's not familiar, those vasomotor symptoms, I probably should have said this sooner. Those are things like the hot flashes, the palpitations, the night sweats, the kind of the
Yes.
traditional type of joking with other people about their moms, of like things that we saw our moms do when we were younger. That's kind of what we're talking about when we're talking about those vasomotor symptoms. You mentioned there's not a lot of research out there about the body aches and different musculoskeletal things. There was that paper that recently came out, though, I think within the last year,
It
that
came out in
talked
the
about,
Women's It's by Vonda Wright. She wrote about the musculoskeletal syndrome of menopause, but that
yeah,
that wasn't an RCT. That was just her
no,
just
no.
yeah, exactly.
Yeah, I think that's fascinating though, because we now
Validate.
know that we have estrogen receptors in places other than our ovaries and other than our reproductive system, which
Yeah.
really does open the door to all the other places that we may have these estrogen receptors. And it's like, if you don't have the right, nucleotide to kind of band them and look at them under a PET scan or a certain kind of MRI, you're not able to pick up on how saturated these estrogen receptors are in different places. But I do find it absolutely fascinating that we're finding it in joints. Have you found some of your patients can resonate with that kind of whole body ache
Oh,
joint?
1,000%. I mean, I have even myself, like, I thought I had arthritis in my right knee. Really wasn't even sitting cross-legged for a couple years, and then one day I just noticed it was gone, and I was like, I had been on hormone therapy for a couple years, and I have no more pain in my right knee, where I suffered for that with that for years. And absolutely, my patients report when I start hormone therapy, most of the things that they are talking about, their chief complaints or their concerns, definitely resolve, 85% to more. They have, improved mood, improved energy. They are sleeping better. They are absolutely feeling less achy. They have more energy. So, it's a widespread effect from estrogen and the estrogen receptors absolutely being everywhere in your body from, your hair follicles to your skin to your joints to obviously in your brain. And it's also sometimes a downstream effect of just getting better sleep. We know that night sweats and hot flashes will wake you up at night. And if you're waking up at night, you're tired the next day, there's a downstream effect from not sleeping. And that could be you're exhausted, you're looking for like quick sources of energy within food. So we know women that are not sleeping that well, that are perimenopausal, are eating more frequently, they're eating more carbs. They're looking for that fast source of energy. So that can cause weight gain. They're not feeling as well, so they're not going to be exercising as much. We know as we lose estrogen, it's a little bit more of a fight to maintain our muscle. When we lose muscle, our basal metabolic rate goes down. Muscle burns more calories than does or any other in our body. So it's it's kind of a wide reaching effect of sleep. So sometimes even just lack of sleep, even if I have to do it in a non-hormonal way, because I do get a lot of patients that have breast cancer or history of a DVT, pulmonary embolism, or stroke, and they're contraindicated for estrogen. Even if I can cure their sleep non-hormonally, they can feel so much better. So
Yeah.
estrogen definitely has its effects on the receptor, but also just sleep alone.
Yeah, sleep has been great. I've found progesterone has been life-saving for some of my
Great.
patients when it comes to sleep. It can be quite sedating as well, which I didn't realize. I kind of found that out accidentally, and I won't get into how I found that out because I don't want to completely embarrass myself. But I've talked to patients before. I'm like, listen, the lack of sleep, it can be from two different things. It can be one, you're waking up with those vasomotor symptoms in the
Mhm.
middle of the night. And that's actually that was the red flag for me of all of these symptoms and everything that I have been feeling up until now. I was like, "Oh my gosh, am I there?" Because it started when I was 42.
Uh-huh.
42 is when the vasomotor symptoms started, and then I was officially menopause at
Right.
44, 45 is when it was, like, gone. No more periods, everything was gone. But I was working in the emergency department, and, I remember exactly where I was, and I'm usually cold, and I had all these layers on in my white coat, and I'm talking to this man, he's the patient, and the woman is, like, sitting in the chair, his wife, she's an elderly woman, they were in their 70s, and I have, like, my patient list, and I kinda just start, like, fanning myself, and then I start taking my white coat off, and, like, I took my fleece off, and I'm in the room with patients just peeling layers off, and beads of sweat are coming down
Yeah.
my forehead,
Yeah.
and the woman looks at me, and she's like, "Oh, honey, you're having a hot flash," and I was like, "I am," and that was, like, the big red flag, and so, for me, the lack of sleep initially was waking up with those vasomotor symptoms, but then as I started working more into this and working towards that Menopause Society certification, you learn and you get into the data and you find out, I mean, there's also a progesterone-mediated pathway of
Uh-huh.
why you're waking up in the middle of the night. So you might not even have the hot flashes that are waking you up. You're just waking up. And for me, it was like, I think it was around like 3:30 AM. I'm like, "Oh, I'm awake. I guess I'll go, I don't know, write a paper or something." Like I was like wide awake in the middle of the night. So that
I
was
mean,
pretty profound.
I generally start all of my patients on progesterone alone first prior to starting estrogen, even though I fully intend on starting them on estrogen, because I want to see if they notice the sleep benefit, because we can get a sleep benefit from estrogen from, curing the hot flashes, and we can get a sleep benefit from progesterone through working on our GABA neurotransmitter system, causing that sedation and that, relaxation effect. And most of my patients, and I always have them check in before, after they're done their trial of progesterone, before they're about to start estrogen. And most of the patients absolutely say, I'm definitely sleeping better just on this progesterone alone, and I'm feeling better, excited to start estrogen. That's for about 60 to 70% of patients. And then the other 30% don't necessarily notice a difference with the progesterone. And every once in a while, I get a patient where they have a paradoxical effect and the progesterone wakes them right up and they know immediately. So,
Mm.
for them, I find alternatives because no one wants to be woken up at night. But it does work for so many people. And the other thing actually is that sometimes women don't, there's two things. Sometimes women don't recognize that they're having hot flashes. Like when I ask them, are you having hot flashes? They would say no, because they're identifying hot flashes as being waking up in a pool of sweat at night. And that's actually not what most women experience. Those are fear hot flashes. Most women will get a feeling of just being warm that's moderate. They may perspire a little bit, or mild where they just feel warm without perspiration at all. So I ask them if they're throwing the covers off and on at night. And then they say yes. And I say, well, that's a hot flash. You're having them. And there are also studies that women that aren't even aware at all of waking up feeling hot or cold and not throwing the covers off and on, but they've done studies where they're measuring body temperature and doing EEGs. So they're looking at brain waves, and they can see that these mild fluctuations in body temp aren't enough to actually consciously wake someone up, are taking women out of their deep sleep.
Oh, wow. That's
They're feeling tired.
fascinating.
Hmm.
That's fascinating. Yeah, no, it was a total game changer going from the waking up all the time to actually getting sleep, because like you said, I am very focused on my muscle mass. My One of my biggest fears, and I've shared this with listeners before, is to be that little old lady who can't carry her groceries or falls and breaks a hip.
Yeah.
And so I work a lot on my muscle mass and use the body composition machine in my office and everything, and with patients. It's been amazing what getting sleep does in terms of your energy level to actually go and exert yourself physically and put on that muscle mass and just feel better. I tell my husband all the time, I know that if I haven't done a workout for 3 or 4 days, that it probably hasn't impacted my body that much, but just mentally,
Mentally.
the effect of it is I'll look in the mirror after working out for a week and being like, wow, look, I look so much better. I look great. Nothing's changed. But mentally, the lens through which you see yourself and your life and the way you
Yeah.
feel about yourself is so different. So to have the energy from the sleep to do that, I think is such a big deal.
It's huge. It's the biggest thing. I mean, sleep is everything. And for some reason, we really feel the effects so much more in our 40s and 50s of not getting sleep than what we're able to do and tolerate in our 20s and 30s. I mean, as an emergency room physician, and I'm an OB-GYN where we're up for 36 hours at a
Oh,
time.
yeah.
I mean, I can't do that now.
Mm-mm.
It's not, I love delivering babies, but I really can't stay up and all night long and work the next day anymore.
No, I can't think. I
No.
can't think, and I get terrible gastritis, and I was telling my husband, I was like, It is not safe for me to be awake all day," because
Mhm.
I'm not a napper. I've never been one who can, lay down and take a nap. Once I'm awake, and I just keep going until I fall over, which is usually around, 9 to 9:30 PM. So
That's a great bedtime.
yeah, I love that bedtime. I know there's a lot of docs who, can take a nap, or they'll, pepper in melatonin and try and cycle different things, and none of that stuff has worked on me, and so I'm just awake, and by 3 AM, 4 AM, I'm worried about my ability to make these critical decisions in the emergency department. And I feel like in medicine, we have such a grin and bear it mentality where it's like, what, you're weak? You can't meet these excessive physiologic demands that the human body wasn't intended to do. What kind of doctor are you? And then you get a lot of that, and there's this shaming, and then you feel like crap about yourself. The fact is, we're getting older. I said this yesterday. If you just look at biology and evolution, we're not meant to go on being these robust beings off into our older years.
Mhm.
We are supposed to be here to propagate our species, which means biologically you reproduce, you're strong enough to reproduce, you're strong enough to raise your progeny so that they can live independently and survive and continue the species. And I feel like when I say that to people, they're like, that is so terrible. I'm like, but that
Yeah.
is biology. Like biology doesn't care about your feelings and
And
longevity
so
and like,
yet human females way outlive the time when we're raising our progeny until the time they can take care of themselves. Like our kids can actually take care of themselves well before they're 18. You know what I mean?
oh
If they're
yeah,
it's not like we in our society we think, no, they can't take care of themselves until they're 35 years old. No, they can take care of themselves before they're even legal adults. They can feed themselves, clothe themselves,
yeah.
and yet female humans, unlike most other species, live far beyond menopause. So there is a reason for that. And there's like the grandmother hypotheses that we're like now we've become the caretakers of the young so that the newer younger generation of women can continue to have kids and continue to be functional in society while we're taking care of the children is one theory, but definitely there's a reason and a purpose for us, and like our job is to make sure that we can feel as good
Yes.
in those last 3 decades as possible.
I totally agree with you. And that's what I was like, just because biology doesn't want me to be this robust, anabolic person and biology wants to put me into this catabolic stage doesn't mean I'm going to take it.
Right. I mean, I do have patients that are like, I'm noticing my skin sag and I feel dry everywhere. Of course, you can't out eat, out exercise the eventual process that we all die and we
Yeah.
do all get old. But what I tell my patients, because I also do a lot of body comp in my practice, and I'm seeing so many women who are under muscled. And
Oh,
there are even
yeah.
women that are exercising every day. They're doing Pilates every day. I have a patient that runs 10 miles probably 4 times a week and doesn't even own a car because she walks everywhere. And she was actually under less than the 50th percentile for months. And it's so crucial because for them to know now that they have to build muscle and where they're starting from and where they need to go and they're starting to lift weights, people that have never lifted weights before in their lives are like lifting weights in the practice and they're building that muscle and that's what's going to carry them through. Like the muscle mass and cardiovascular are the two number one things that are like really linked with, your health span.
Yeah. I mean, it really is.
Mhm.
I'm so sad. Kim, we're already at 28
I so
minutes.
bad.
What happened? I wanted to talk to you about the different medications. I wanted to talk to you about getting labs. I wanted to talk to you with
Yeah,
these like bioidentical, what does that mean? And I feel like we're just going to have to schedule another session. We're going to have to do a part 3, which don't get mad at me, everyone. It might not be next week. You may just have part 1, part 2, and then there is going to be a pause. We'll talk about a couple things where I'm just flying solo. But then I'm going to try and get Dr. Kim Einhorn back on here again so we can schedule and we'll have our follow-up part 3 where we talk about all these other great things that we didn't get to today. But I love what we talked about today. I thought this
so do
stuff was
I.
amazing.
And I'm happy to come back anytime. There's just so much more we can actually delve into.
Yeah, this has been great. Kim, thank you so much for taking the time out of your schedule, like on a Sunday. She's here on a Sunday, everybody, right? So this is how dedicated this woman is to getting the word out. And like I said on my first podcast, you don't have to be a woman to listen. For all of you men out there, I promise you, if you take notes on what you learned here and you go talk to your partners or your sisters or your mothers or whoever that woman is in your life about what you learned, you will be helping them so much because we just need to spread the word as much as we possibly can.
Amen.
Thank you so much for joining me on this week's No Filter Doctor. If you enjoyed the content, you can follow me on social media. I'm on Instagram, Facebook, and YouTube. You can also go to www.thewholehumanhealthandwellbeing.com and sign up for the weekly newsletter where you will get a link to the blog, that week's podcast, and a health tip of the week sent directly to you. It's important to know that while I am a doctor, I'm not your doctor. This podcast is for educational and informational purposes only, and it's not intended as medical advice. Listening to this podcast does not establish a doctor-patient relationship. The information discussed should not be used to diagnose, treat, or prevent any medical condition, nor should it replace individualized medical care. If you have questions or concerns about your health, please contact your own healthcare provider. Any decisions to delay or forego a medical evaluation or treatment based on the information discussed in this podcast are made so at your own risk. My only financial disclosure is my medical practice, the Whole Human Health and Well-Being. Take care, and I'll talk to you next week.